You're listening to Single Payer Radio, brought to you by Kentuckians for Single Payer Healthcare. My name is Kay Tillow. I'm the chair of that organization, which has existed since about 2004 across the state of Kentucky. And we work to advocate and enact a single payer plan that would cover everybody in our country for all medically necessary care. And we do these radio shows that are brought to you 3 times a week. You can reach us at kyhealthcare.org. And this is WFPL Radio 106.5. And today we are going to be having a discussion about Medicare and Medicare Advantage. What is the difference? What is the issue? It's important right now. Well, it's always important, but it's important at this particular moment because open enrollment has started. And people are being asked to take a look at plans and to sign up for a new one if they want to change. So there are a lot of issues involved for seniors and for the totally disabled who are on Medicare plans. So we hope to bring you some of those issues and to help with understanding by the public about what is involved with this program. Medicare is, of course, the program for which our seniors are eligible at age 65, but it also includes those who need dialysis and those who have been permanently disabled for at least 2 years. So I'm going to let my other members of Kentuckians for Single Payer introduce themselves, and then we'll get started. Steve?
Hi, Kay. My name's Steve Katz. I'm from Lexington, and I've been a member of Kentuckians for Single Payer Healthcare for, well, I think it's coming up on 4 years now, believe it or not, Kay. I think it was early 2021, and we're nearing 2025, so that's 4 years. But that's just about the same amount of time that I have been a Medicare beneficiary myself. So perhaps what I've learned along the way is something that I can express here in our discussion today.
Thank you. And Harriet?
Hi, I'm Harriet Seiler, and I've been a member of this group, I believe, since 2004, which is a pretty darn long time. I too am a Medicare beneficiary. Well, I'm eager to discuss this with Steve and yourself, Kay.
Thanks, Harriet. And Evan?
Hi, I'm Evan Hawthorne. I'm a second-year medical student at the Kentucky College of Osteopathic Medicine here in Eastern Kentucky. I've only been a member of this group for a few months now, but I'm also a member of Students for a National Health Program, or SNAP, and I'm happy to be here.
That's great. Okay, let me just see if I can lay out kind of some of the basics. Medicare traditional is funded, the whole program is funded federally. We all pay into it through our payroll deductions. We and our employers pay into it. So it's funded federally, it's funded with public money, with tax money, and it's been in effect since 1965. And there is a traditional Medicare, which is publicly administered and uses only about 2% for administration costs. Then there is the privatized part of Medicare, and that is called Medicare Advantage. And unfortunately, that is growing larger and larger and taking up over half now of the recipients of Medicare. It is privately owned plans, and those are for-profit plans who make more money when they deny care. They use about 15% of the money for their administration and for profit. That's their overhead. So they are not efficient. They were supposedly enacted in order to save us money and improve efficiency and improve quality of care. And they have not been doing that. One of the consequences of their participation in our Medicare plan, which is a beautiful plan because it's expansive and publicly funded and covers everybody, their participation by the private companies, Humana, Cigna, Anthem, Aetna, et cetera, complicates the process and forces us once a year to go look and see if your plan is changing and if you need a different one. Causes a great deal of stress. And we're now in that period of time where seniors are being asked to look at plans and to choose one. That period started in October and it ends December 7th. So we're going to open this discussion with discussing the differences between the Medicare Advantage plans and the traditional Medicare, and try to help to spread some truth amidst this complication in our lives. So we're going to discuss the issues that are involved, and I would welcome whoever would like to speak.
I'll start, Kay. From my perspective, the thing that Medicare is most noted for is its complexity. It's confusing. I mean, you've got Part A, Part B, Part C, Part D, and then you've got the supplemental Plan G, Plan N, Plan F, and however many more. It's a lot to keep up with. And people that are new to the system, when they turn 65, they become eligible. They can easily get confused because of that complexity. And even if you think you know so much, chances are you don't know about this because it's such a thick manual that they put out every year, Medicare and You, that if you're going to remember all of the nuances, your mind's going to spin. I thought wrongly that when I turned 65, I wouldn't have to spend very much for my healthcare insurance anymore because I'd be eligible for Medicare. That's wrong. You still have to pay a premium to cover your Part B expenses. That's for outpatient expenses, doctors and such. And currently, it's $174 a month, I believe. I learned from my brother, who had a very bad experience when he turned 65. He also had a life-threatening health issue that required hospitalization for an extended period. And he mistakenly thought that he could get away with just having Part A and Part B coverage without having a supplement plan. Well, with what it costs to be in the hospital for an extended period of time, you're talking potentially hundreds of thousands, maybe $1 million, and Medicare only covers 80%. So you would be stuck with 20% of the bill didn't have a supplemental insurance plan, or alternatively, Medicare Advantage, Part C. Well, Medicare Advantage, a lot of the circles in which I travel, should be called Medicare Disadvantage. And we're going to be getting to that later in our discussion. But, the main purpose of, as far as I'm concerned, of either Part C or a Medicare supplement plan, also called a Medigap plan, to fill the gap of that 20% that you're exposed for, is necessary. You know, if you've got $1 million bill, you're going to have to come up with $200,000 to cover it, unless you have that supplemental insurance. So I found a broker, a guy I use. I found him on YouTube. He was explaining all of these complications, and he's done a good job for me. He's based out of Florida, but I have a Medicare. I have traditional Medicare and a separate supplement. Plan N is the one that I have. Harriet, what about your
Well,
experience?
well, Steve, I was just going to say that I have that too. Absolute traditional basic Medicare. But I too, when I heard that if I was in the hospital, I'd have to pay 20% of a rather large bill, that I then have purchased a supplement. And I have had wonderful care, wonderful coverage. I do pay $20 a visit as a copay when I go to my doctor's. And I have, at early in the year, in January, I always have a deductible of about $240, which, that's money out of your pocket, but it's not as bad as some deductibles. But it's that extra cost for the supplement that scares people, and they think, I can't do that. I can't pay that amount every month. Whatever I pay quarterly, and I think I'm now paying, it was about 550 a quarter. I think I'm paying 600 and something a quarter. Um, excuse me, but it's that fear that makes people jump to Medicare Advantage. And they think, oh, listen, what's his name? The football guy, Joe Namath and Dynamite. Those guys must be right. They couldn't possibly be wrong selling me these Medicare Advantage plans. And people have just scooped them up and they've been duped, because what's happening now is a lot of hospitals are saying they won't take Medicare Advantage patients. And they get trapped in networks and might lose the doctor they're so fond of. So I hate to start with what's bad about the good, but I hope we're going to talk about what's bad about the bad Medicare Advantage. But I understand that there are people who think they can't afford the supplement and they can't risk having a hospital bill they can't pay, although a lot of people are trapped in medical debt. And they think it's an easy out to get an Advantage plan. So I think I should probably pass it along now to someone else who can talk more about what's going on with Medicare Advantage and why we call it Medicare Disadvantage.
Okay, thank you, Harriet. Yes, many seniors, as a matter of fact, most seniors live on modest incomes. They cease the payroll that they've been on, and the pensions in our country are really inadequate. And so people are on very limited incomes, and that is the reason why people are choosing to go into Medicare Advantage. It's not a free choice. It means that on a monthly basis, you can get away with something smaller than the hundreds of dollars that it costs to purchase a Medigap plan, the supplementary plan, and the drug plan. So if you don't get sick and you don't need to use it, you can come out better financially if you take a Medicare Advantage plan. The problem is that the whole purpose of this health coverage is to take care of you, your health expenses. And that is what Medicare Disadvantage is no good at, because these companies are doing this as a profit-making scheme. They're very interested in limiting the amount of coverage that you get. So for instance, they have something called prior authorization. That is, if your physician says that you need some surgical or some test or surgery or some treatment, the insurance company first has to decide whether they're going to approve what your physician has said. And this is a major barrier to care, for it can take a very long time, and there are huge numbers of denials and delays within the Medicare Advantage plans. And this can be deadly. That is one of the worst things about the Medicare Advantage. You cannot get the access that you need to the care that you need. And it's particularly destructive if your condition is something that needs immediate treatment, such as cancer or heart conditions, etc. So it's a barrier to the care. Evan?
I think before we get too into the details and the nitty-gritty of the problems that Medicare Advantage have, I think it's important to clearly outline exactly what we're talking about. It's obviously very complicated. I myself had very little idea of what it was or how it worked. So I think it would be beneficial to clearly explain really briefly what Medicare is and how it's broken down. So there's Part A and B are the original. Part A is hospital insurance. It covers inpatient care in hospitals, skilled nursing facilities, and hospice. Part B is your medical insurance. It covers services from outpatient doctor's visits, home health care, medical equipment, and preventative services. Part D is drug coverage, helps lower the cost of prescription drugs. And then there's Part C, which is Medicare Advantage, which acts to bundle different parts of A, B, and D, different amounts of it depending on which plan you take. And then there are parts F through N, which are the named Medigap policies. So A, B, and D are publicly funded and supplied, and then Part C, the Medicare Advantage, as well as all of the Medigap policies are, while they are funded publicly, they are provided privately. So that's where you start to get into a lot of the issues that you see that you were talking about with prior authorization and the burden that is that takes on administration and physicians. There's also the massive widespread corporatization of medicine, induced utilization, overpayment because of things like upcoding, quality benchmarks and bonuses, and obviously the extreme network restriction that is seen in a lot of Medicare Advantage plans. But yeah, wanted to delineate really quickly.
Thank you, Evan. That's very helpful. I saw Steve.
One thing that you mentioned, Evan, is when you sign up for Medicare Advantage or a Medigap plan, when you first turn 65, there is no medical underwriting necessary. Everybody is eligible for every plan without having to be with any look back at your health history. You're in, and the price that you pay is the same, but that doesn't last forever. If you sign up initially for a Medicare Advantage plan, and for whatever reason you're dissatisfied with it, you can't switch back to a Medicare supplement plan and get back into traditional Medicare with that protection for that 20% that you're exposed to, unless you're subject to medical underwriting if it's more than a year from your first signing up for Medicare. So you've got a grace period when you don't have to qualify for medical underwriting to get a Medicare supplement plan, but afterwards you do. And you can be denied outright, or you can be forced to pay much higher prices for your premiums if it's past that initial coverage period. So there are 4 states that have prohibited such discrimination, such treatment. So everybody can still get into a Medicare supplement plan in those states without being subject to medical underwriting. I think they're all in the Northeast. I think it's New York and Massachusetts and Connecticut and one other.
Maine, I
Right.
think.
Right.
Maine, okay.
Steve, explain quickly what medical underwriting means.
Yeah, they're going to look at your health history and
So it's
see if you're
pre,
sick. And
it's
if you're
pre,
sick enough, they don't want you.
if it's
You know, they-
pre, they'll penalize you for having a pre-existing condition.
Correct. Correct.
Okay, thanks.
Yeah, and as far as the pre-existing conditions are concerned, uh, um, it's hard for me on the outside to know exactly what they're going to look for. How badly sick do you have to be for them to jack the prices up or deny you coverage? I'm not sure. Yeah, you have to apply and find out. I guess they have different standards.
One of my doctors the other day told me that for his Medicare Advantage patients, the insurer expects him to send not just his area of illnesses that the patient might have, but her entire or his entire medical record, which means they're looking to see what's wrong with you. So anyway, well, I didn't mean to digress, but the whole point is it's not easy then to switch from Medicare Advantage. You're really trapped in our state anyway. You're trapped. You can't get in to a regular Medicare with a supplement plan
Yeah, and the
without
Medicare
paying
Advantage.
more or being penalized somehow.
In the Medicare Advantage plan, you're probably, as Kay pointed out, you're probably going to be very happy with it if you don't get sick. If you don't actually need to use the health insurance, it's going to be just fine because you're, in many cases, not paying any premium for the Medicare Advantage plan. Because the way they make their money, these insurance companies, they get capitated payments. They get paid by the head. They get paid for every member, every beneficiary, X amount of dollars. And if they have a particular sickness, they can get coded so that they get paid even more. But
By
they get
paid, you mean paid by Medicare?
correct.
Yeah, because that capitated payment comes from Medicare to the insurer per patient.
Whether they use services or not, the insurance company gets the same amount of money, and they get to keep more of it if they don't have to
spend
give
it.
those services out. Evan, what do
Right.
you got to say about it?
Okay, Evan?
I was just going to get into the specifics of what you were talking about with upcoding. They do get paid on a per head basis. So they do love having people in their plans that don't use the insurance at all. But even when they do, they find workarounds to bilk as much money per patient as they possibly can. One of the biggest ways that they do that, that Medicare Advantage does that, is through upcoding, which is kind of complicated. Patients in Medicare Advantage are given a risk score related to their diagnosed conditions. And that score is used as a multiplier for the amount of money that Medicare pays to the Medicare Advantage insurer to manage their care. So the more diagnosed conditions and the more severe, the more money that insurer receives from Medicare. So this creates an incentive for insurers to add diagnoses or inflate severity regardless of their relevance. And in 2019, the average risk score in Medicare Advantage was 20% higher than it would have been in traditional Medicare. And MedPAC estimated that accounted for at least $20 billion in overpayment to Medicare Advantage that year. So that's a whole lot of money that is coming out of traditional Medicare's bank account and going to private insurers for things that more or less aren't really real or really matter. And they hold trainings on it. They will go and teach providers how to upcode their patients in the way that gets them the most money.
That
So a
can't be,
cough, does a cough get listed as pneumonia when it was really just bronchitis? That kind of thing they exaggerate.
Or
Yes.
they can code obesity as, morbid obesity.
Oh, okay, right. So it's exaggerating your condition. So they get more money. Do we know now what the basic amount is that Medicare gives to an insurer?
I think it may not be the latest figure, but I think it's something around 12,000 a year. So that money goes to the insurance company, to Aetna or Humana, from Medicare funds. And if you don't use it, if you only go get a couple of doctor's visits, most of that 12,000 stays with the insurance company. But they can get a lot more than 12,000 if they assert that you are sicker. So they have a practice of sending nurses or sometimes physicians to people's homes for the specific purpose of trying to log in more diagnoses that aren't really real, that are things they aren't really spending money on, but that can allow them to double and triple that. So it's possible to get 36,000 a year for a patient if they upcode it in a way that, that is really unscrupulous and wrong. And what this results in is that our public money is being wasted in overpayment to insurance companies. I think that the government body that Evan mentioned, the MedPAC it's called, I'm not sure I could tell you what those letters stand for, but I think they say that about 80 billion a year goes out in overpayments to the insurance industry. The Physicians for a National Health Program has said that they have done studies that show that it's even much greater than that, and it could be as high as 140 billion. So this means that the precious funds that we need for our healthcare are going to unscrupulous companies who are not using it for care, but using it as a cash cow and living high off of the healthcare that we need to be able to take care of the seniors. And of course, they are always saying, Medicare's going to run out of money. And, hopefully it's not, but we need to look at programs like Medicare Advantage and remove these obstructions to care and this unnecessary spending of our money. Does anybody know what lemon dropping and cherry picking is?
Right.
Well,
Yeah.
lemon dropping is getting rid of the lemons, getting rid of the people that are sicker than you want in your pool of beneficiaries. If they're sicker than you want to have to deal with, they're going to cost more money. So get rid of them. Make them want to leave. Make them want to go back to traditional medicine.
Yeah, make them unhappy. Right.
And cherry picking is the opposite. Try to get as many healthy people as possible, the ones that are not unwell, that you don't have to spend money on, that are not sick. You want them to be the greatest number of beneficiaries in your pool.
And their chances are they're younger and healthier.
A lot of the marketing that a lot of these companies do, these Medicare Advantage companies, they talk about gym memberships, and a lot of times they'll have these informational events. They hold them on upper stores. So somebody upper stories of a restaurant that you can't easily get up there with a walker. If you need a walker, they don't want you. That's the way they drop the lemons, but and they pick the cherries.
Mhm.
Well, and they have other, I mean, sort of kind of unethical and unsavory things that they're known for. And I mean, these are companies like Humana and Anthem and Aetna and Cigna and all of them, even the hospitals themselves now, or big health systems like Baptist Health System, are dropping Medicare Advantage plans. And they're saying that among the common reasons are excessive prior authorization. That is, they have to, you constantly get turned down and they tell you have to go back to your doctor, and the poor doctors are exhausted having to constantly reauthorize the treatment that you need. The other thing is the denial rates. And now you can, I think, find articles that will give you now they're probably not complete, but the denial rates per plan. Like if it's United Healthcare with high denial rates, that means they're denying patients care that they need. And I mean, they could die if they're delayed or denied. And the other thing, apparently, from the hospital's point of view, is that the Advantage plans. Well, actually, my doctor referenced this the other day, said that he is paid half for a Medicare Advantage patient than one on traditional Medicare, as I am. And so they just make a deal. They say, you want to be in a contract with us? We're just going to pay you half of what we're paying for other people. And, some doctors, maybe smaller practices, etc., they have to accept it. And then the other thing is slow pay from insurers. So they owe money to the hospital by the contract that they have, but they're slow pay. Well, that's my little tidbit that I got from an article in, just a minute, I'll have to tell you. I've forgotten. I'll let you know where I got that one.
One
From Becker's, sorry. And
Okay.
Becker's has a lot of articles about health insurance.
One of the beautiful things about traditional Medicare is that it's national, and almost every physician and hospital and institution is involved. So, if you get a cancer, you need to go to Sloan Kettering or to the Mayo Clinic or to MD Anderson or Vanderbilt, you can do it. But you're not likely to have that access if you're under Medicare Advantage. Evan?
Yeah, so I have a good bit on network restriction, which is something that Medicare Advantage is really, really bad about. And all of this data comes from primarily KFF. But like you said, traditional Medicare allows beneficiaries to access care at nearly any hospital or any doctor in the country with no additional out-of-network fees or differences in payments. On the other hand, over half of Medicare Advantage plans are HMOs, or health maintenance organizations, which are just networks. I think it's almost 65% of them. And they tend to be very restrictive, very small, have very little out-of-network coverage, and require referrals for specialist care. And so KFF looked at how these HMOs operated, and they found that the average Medicare Advantage network excluded over 50% of physicians in a given county, which means right off the bat, if you enroll in that plan, you cannot see half of the doctors in your area. And they found that it preferentially excluded physicians who tended to treat patients of a higher medical risk. So again, penalizing providers that cater to those who actually need more care. making it just much harder to see someone who is capable of providing care to you. And then there's the prevalence of ghost networks, which this is actually from the U.S. Senate Committee of Finance. They conducted a study and they found that over 80% of the listings for mental health providers in the studied Medicare Advantage plans were inaccurate or unavailable. So of the 120 provider listings, they successfully scheduled appointments with only 22 of them. The vast majority of those were just, they did not exist anymore. So they're listed on, oh, you can see this doctor, and then you look them up, and there's the picture on the Google search that used to be a doctor's office, and now it's a store or a restaurant, and it just hasn't been updated. So even if the plan looks like it features a lot of physicians in your area, there's a very high chance that it does not in reality.
Yeah, and that's especially important now, Evan, during open enrollment period, because consumers are shopping for plans. They want to see that their providers, their doctors are in the network of this particular plan or that particular plan. So they go to the websites for those plans and they see the listings and they see their doctor is listed, but in reality, they're not. They're not available. They've been dropped. The plan has changed. They don't update them frequently enough. And the network that you thought you were joining is a phantom.
Mhm. And the other thing that can happen is that those insurance companies negotiate with the hospitals and physician practices, and they have a contract for a certain period of time. So that contract may end in the middle of when you're getting treatment, and your doctor is no longer on the list, or your hospital is no longer on the list. It's a constantly changing arena in which we live. And it's really unfair to people to have to choose every year from amongst plans that are inadequate and which, are not clearly and transparently open. And it's impossible for the average person to know all of the ins and outs. It's a very stressful process to have to go through annually.
Well, not just the average person, but nobody has a crystal ball. Nobody can see the future and know what special providers they're going to need, what specialists they're going to have to go see, who they're going to need to be covered in the network of their plan.
Harriet?
Well, and earlier I talked about people being trapped. And right now in our state, in Kentucky, we have two large groups of retirees that have been signed up for Medicare Advantage really through no choice of their own. Either their employer or the head of their group made this decision, maybe cut some kind of a deal with Humana or United Healthcare. And now that entire group is in a Medicare Advantage plan. Now, if you're the insurer and you've got every state retiree in Kentucky signed up with you, then I suppose you do try to take care of those people so there won't be a lot of complaints. However, we don't kind of have a record of that. And the teachers union and the state retirees, they need to be aware of the fact, are their sisters and brothers being denied treatment? It's the kind of thing that people think, oh, well, the teachers picked this. This must be all right. Well, it's all right if they follow through with their promises and you really are being cared for when you're sick. But if you're being held up by prior authorization or denials and you can't, and you know of friends or what did I say, brothers, sisters, and brothers in your union or whatever, and not being covered. I know Kay knows about people in New York and other states who have said, don't give us a Medicare Advantage plan. We want traditional Medicare, and our retirement should pay for the supplement. Correct me if I'm wrong,
Yes,
Kay.
and they've been winning. There are a number of groups that have become aware of how inadequate the Medicare disadvantage plans are, and of how that denies them the care that they really need. And they've been fighting against this automatic putting of them into Medicare Advantage. And the New York City Organization of Public Service Retirees has been filing suit against the effort to place them in an Aetna disadvantage plan, and they've been winning. They have now won in 10 different courts that say that, yes, it indeed does deprive people of care, and it's inferior, and it's not what they had been promised, and that it's illegal to take that away from them. So there is a fight back in New York, in Delaware. They have been fighting it, and I think they've won some victories. In Vermont, they have stopped it, at least for now. So there is an effort to make this not happen. I think Connecticut, they've set up an effort to go after it. You know, there are 13 states where the state employees are automatically put into Medicare disadvantage, and they have no say at all. And Kentucky is one of those. So our state workers, and that includes our county workers and our school employees other than teachers, are in Humana Advantage plans. And of course, Humana has announced that they're cutting back on benefits, and that they're cutting back on the number of plans offered, because they say they haven't been making as much money as they wanted to. And the state employees are in Humana. The retired teachers in Kentucky are in United Healthcare. That's also an Advantage plan. And they were not asked if they wanted to go. And we would love to hear from people who are in these plans to see how it's going for them. You can contact us at kyhealthcare.org. That's our website where you can get our contact information.
Kay, we talked about prior authorizations briefly earlier in our discussion. One aspect of that is that the rate of denials for the prior authorization requests is going up, and going up dramatically. The percentage of those denials that are appealed has been traditionally minuscule. Only about 10% get appealed, but of those appeals that are filed, about 80% are successful, because so many of those denials are unjust. So many of those denials are supposed to be covered by Medicare. The law that authorized Medicare Advantage plans is supposed to require that they be administered along the same lines, with the same rules as traditional Medicare. Evan, I see you've got a comment about that.
I wanted to talk about prior authorizations from the standpoint of administrative burden.
On physicians, right? Go
Yeah.
on.
So obviously with Medicare Advantage and the network restrictions, physicians can't refer patients to the preferred or the convenient specialist. And that right there increases odds that the patient will abandon treatment or become non-compliant. But additionally, Medicare Advantage uses prior authorizations at a rate far exceeding traditional Medicare. The AMA surveyed a group of providers, and 31% of them reported that PA criteria, prior authorization criteria, rarely or never followed evidence-based guidelines that are approved by medical specialty societies. So they're denying care on more or less a whim, definitely not on what medical societies recommend or what evidence would suggest patients should get care as. So the administrative burdens of PAs are significant. 88% of physicians describe the burden of PAs as high or extremely high. 5% of physicians surveyed in the same AMA study reported hiring a staff member to work exclusively on prior authorizations. That's a lot of extra work and time and frustration just so insurance companies can save some money. And
For
so
profit.
exactly. The
Right.
Medical Management Association asked another group of physicians which type of policy was the most burdensome, specifically talking about prior authorizations. 46% of those surveyed said Medicare Advantage. Just 4% of them named traditional Medicare as being the worst for PAs. So clearly, Medicare Advantage uses a lot more prior auths or requires a lot more prior auths. And
Well, and didn't we hear when there was, the first onslaught of news about prior authorizations that they were using algorithms and just sort of automatically you'd be up you'd be denied and a prior authorization would be requested from your physician. And I mean, I can remember when we would talk about the fact that we have so many payers, that we have all these insurance payers. And I can remember we had a slide that showed if you were at Duke Hospital, you had, if you were working at Duke, you had to get approval or, yeah, you had to work with, let's say, 1,000 insurers. I think it was 1,800. I don't remember the number. But at the University of Montreal in Canada, where they have single payer Medicare for all, they probably had 2 people that had to, and those people just had to get the bill from the hospital and pass it to the government, and the money went into the bank account. So, I mean, the amount of, we don't want people to lose their jobs, but those people could be working in healthcare instead of having to be on the phone arguing with some insurer to get needed care for a patient.
Well, what you've just described, Harriet, is why one of the many reasons why the United States healthcare system is the most expensive in the world. And yet it doesn't get anywhere near the results that so many other nations are able to provide for their citizenry. It's because of the perversion of the incentives. It's the fact that in this case, this discussion of the Medicare disadvantaged companies, they make their profits from denying and delaying care rather than providing the care. Instead of being paid for work that's performed, they're being paid, like I said, on a capitated basis, and that gives them all the incentive in the world to deny and delay care to make more money.
And you should know that the phone numbers that come on your TV screen selling Medicare Disadvantage plans, those phone numbers take you to a broker, an insurance agent, and those insurance agents are paid according to what they sell. The highest rate for them to make money is to get you into a Medicare Advantage plan. So you are not dealing with someone who has your interest first, but who has a private profit interest in getting you to take that plan. Evan?
And I think all of these problems are kind of exacerbated by the growing corporatization of medicine, on top of the more or less malicious advertising by these companies pushing Medicare Advantage plans, and the way that large groups of people are automatically enrolled in them, like the retirees of all of the teachers in the state of Kentucky being forced into Medicare Advantage plans. And while they technically have the option to change their plan during the open enrollment period, this circles back to the pre-existing health conditions. They are subject to the medical underwriting requirement where they have the option to change, but they may be forced to pay a lot more, or they may be denied outright. And that's just kind of an overarching issue with Medicare Advantage plans and how it ties into the corporatization of medicine. From 2019 to 2021, the percentage of corporate-owned medical practices increased 39%. That's a huge jump for 2 years. And so these private equity-owned health systems are increasingly adopting Medicare Advantage plan contracts and taking on global risk models where physicians only make money if they stay under a certain budget. And they encourage upcoding and the careful management of care, and really just try to encourage denying care or being as stringent as possible. And they do it from the top down. They do it as the administration of the hospital because they're private equity owned and they're looking to just extract wealth in the short term. So it's bad for the patients that use those facilities. It's bad for the physicians that work there. And it's really only good for the 3 people that own that firm and the 3 people that are at the head of the insurance company.
Right, right.
Well, the financial class that owns the stocks and all of those healthcare insurers and providers are getting, they're getting their share. And that's the basic problem, is that rather than a healthcare system, we have a wealth transfer system. Right. Where Humana has recently gotten out of providing employer-based plans and Affordable Care Act plans. They only want government plans that they can exploit in this manner on both ends.
Right.
Like you said.
Harriet?
Well, I know that we might not have time to do this, but it was Steve actually who suggested that we call our state health insurance plan office SHIP.
SHIP, yes.
And
they give advice.
And they give advice. So I'm sure there are people listening who got our clear message that we don't like Medicare Advantage plans and recommend traditional Medicare with a Medigap policy. However, if you need more information, and apparently pretty dependable information that is, and they don't sell private insurance plans, call our Kentucky SHIP office.
And you can find it online at shiphelp.org. And if you put that into your computer, you can come up with the phone number. And that is a publicly funded office where you can ask questions that you might have and where the advice does not come from someone who will profit from selling you something. So if you have questions, we encourage you to go there. If you have things you'd like to tell us about, we urge you to get in touch with us at kyhealthcare.org. We are concerned about this. We're concerned about the private plans in Medicare. We're also concerned about the private for-profit plans that are in our system as a whole, that are making our healthcare much less efficient, much more complex, and much more cruel and inhumane than it should be. We've just seen the most recent study by the Commonwealth Fund has told us that of the wealthy nations in this world, we come in dead last in terms of the efficiency and quality of our healthcare. We are not doing a good job in outcomes. We are not taking proper care of all of our population. And of course, that is why we as an organization are working to enact an improved Medicare for all that would cover everyone for all medically necessary care. Steve?
Okay, while you were talking, I jumped on my computer and I typed in shiphealth.org, and it took me to a site that was trying to sell me a Medicare Advantage plan, because the actual website is Ship Help, not Health.
No.
SHIPHELP.org. Please, people, don't make that mistake that I just made.
Well,
Yes.
and I called a number that I put up on Twitter, and I don't think I can grab it right now, but it was for Kentucky. Tell me again, Steve. Ship Help,
State
HELP.
Health Insurance Program. State Health Insurance Program, SHIP. SHIP Help. No space
Yeah.
in between them.
Okay.
SHIPHELP.org.
Oh, good, good. But anyway, I called the phone number and I got a very nice person who said, I was double checking the phone number, and then she wanted, very nicely recommended that I be transferred to the person handling my county. And earlier I was talking to Steve, and he said they've divided the state up, and they will give you solid advice. They might not be able to answer every question, but they won't be trying to rip you off like Joe Namath on TV.
Well, thanks to all of you for participating in this single payer radio show. It's brought to you by Kentuckians for Single Payer Healthcare, working to win a national single payer plan that would cover all of our people, save us money, save our lives, improve our health, improve our life expectancy, and get us up off of the bottom of the failing healthcare system that we now are working to survive. So thank you, Evan Hawthorne, Steve Katz, Harriet Seiler, for joining us today. And we hope you'll listen to Single Payer Radio again. Thank you.
Views and opinions expressed on this program are those of the speakers and not the radio station. Once again, thank you for listening.